So good morning, good afternoon, good evening from wherever you're joining us. My name is Jessie Lane. I am the Communications Manager for the CHAMPS Program Office, and I'm pleased to welcome you to the third of our series of webinars here at CHAMPS. We started in August of last year with Dr. Dianna Blau introducing us to CHAMPS data and how it's generated and how it can be used. We then did a wonderful webinar with our social behavioral sciences team, and they presented on their work. And now Dr. Blau is back with us, this time to go a step further into exploring CHAMPS data. We're glad you're all here. A few orders of business before we get started. As Andeshe already pointed out, we have a Q&A box at the bottom of the Zoom screen. That's the easiest way for us to see your questions and address them one by one. We will monitor the chat as well, but it's easy for questions to get lost there, so we encourage you to use the Q&A feature. We will answer questions throughout the webinar as they come up. Unless they're bigger questions, we'll save those for the end. We've set aside some time for Di to answer questions then. This is being recorded, and we will make the recording and the slide deck available to all of you on our website, and we'll also email them out afterwards. And I think that's everything from me, and I'm glad to introduce Dr. Dianna Blau, who is the Senior Director of Science here at CHAMPS. Di, I'll let you take it away.
Thanks, Jessie, and welcome to everyone. I'm glad we can talk together this morning, this afternoon, this evening about CHAMPS and a little bit into the data. I'm going to turn off my video, but we'll come back on answering questions just so that I can get the screen out. So to begin, I want to just remind everyone, if especially for those just joining one of these CHAMPS webinar series, about the objective of CHAMPS, which is the Child Health and Mortality Prevention Surveillance Network. There are three main objectives. One is to better characterize the main causes of under 5 mortality in areas where it's highest. And CHAMPS achieves this by having a more comprehensive approach to mortality surveillance, including more complete data collection and diagnostics, where minimally invasive tissue sampling, or MITS, is an example of this. And I'll describe this in more detail in a few minutes. Another objective is that this quality cause of death data from the CHAMPS network is available in real time so that there's no lag into translating into action to help reduce the morbidity and mortality in children under 5 at all levels, at the local, the subnational, and national levels. For example, within a specific surveillance site, if the team is seeing numerous deaths attributed to insufficient clinical diagnosis and/or management, they can immediately take action by, for example, retraining in appropriate clinical management for certain conditions. And finally, CHAMPS aims to serve as a platform for sites to leverage the CHAMPS investment in a more large-scale effort. For example, here looking at vaccine effectiveness, especially those that might have been prioritized based on CHAMPS data. An example of this could be a Klebsiella vaccine to prevent neonatal sepsis. And again, we'll go into a little bit more detail showing that data in a little bit. We hope that all of those on the call today will be excited to look at and use CHAMPS data to further take action to reduce under 5 mortality in your area or other areas. So with this third presentation in the webinar series, we aim to provide a more in-depth overview of the CHAMPS methods and highlight the key data findings on the causes of under 5 mortality, really focusing on that preventability and to set the stage for more discussions on how to use the data further to reduce under 5 mortality in areas where it's highest. So currently there are 7 active sites enrolling deaths. These include 2 countries in Southern Africa, so South Africa and Mozambique, 2 countries in Eastern Africa, in Kenya and Ethiopia, and 2 in Western, in Mali and Sierra Leone, 1 current site in South Asia and Bangladesh, and a site launching soon in India. And very recently, we have invited 2 additional countries to the CHAMPS family, in Pakistan and also in Nigeria. And this just shows that within the network, there are many, many partners and collaborators involved, as well as in each of the individual surveillance sites. So in each, and now just to turn a little focus, a little bit more deeper dive into the methods in CHAMPS. At each of those sites within a defined catchment area, there are local teams that lead the CHAMPS processes. And due to the sensitivity in many cultural settings of under 5 mortality in general, the first step in this cycle is community assessment and engagement. And this strong social behavior work, which was outlined in the webinar 2, lays the foundation for the acceptance of the surveillance components. And the surveillance components of CHAMPS includes demographic surveillance, or DSS, so that a denominator is available for calculating site-specific cause mortality rates that can be used in extrapolating CHAMPS data wider out. In addition to the mortality surveillance, we're also beginning to incorporate systematic pregnancy surveillance to ensure that all stillbirths and neonatal deaths are captured, and also to capture more complete maternal health information on the population. So once a death is identified, in all of the deaths that are reported to the team, the family is approached for CHAMPS enrollment. And this includes asking for consent for a verbal autopsy and any clinical data available. And for those deaths that occurred within 24 hours and the body is still available, the family is approached for the minimally invasive tissue sampling. In this sampling, again, this is for when the death is notified within 24 hours and the parental consent, in addition to the verbal autopsy and the clinical abstraction. There are clinical specimens, blood, CSF, NP, swab, and stools collected, as well as tissue specimens targeting the liver, lung, heart, brain, previously bone marrow, and then placenta when available. All of these specimens are collected in a standard way across all of the sites in the deaths, as well as photographs and physical measurements to assess the nutritional status. For the specimens that are collected, there is an extensive diagnostic array that occurs. The blood and CSF are done with traditional microbiological culture. There's standardized HIV, TB, and malaria testing done on the blood. And the blood CSF, the NP swab, the lung tissue, and the stool specimen or rectal swab undergo extensive molecular testing for infectious disease targets using a Tachman array card. Across 4 different cards and with those 5 specimens, over 130 pathogens can be detected or tested for. And then all of the tissues undergo routine histological evaluation to look at what's going on in the tissues. Is there disease processes, or are there abnormalities seen that could give insight to the cause of death? Additionally, more advanced diagnostics or histopathology can occur at a reference lab here in Atlanta, doing specific testing for infectious agents or other markers within those areas of the tissue where there shows some lesions. So after a case is enrolled and undergoes amidst all of that information that's collected during the procedure, as well as the verbal autopsy and clinical abstraction, go to a cause of death determination panel. And this, or called DeCoDe, are a group of experts at each of the sites that include clinicians, neonatologists, obstetricians, pathologists, microbiologists, public health specialists, SBS, some of the social and other team members. And this panel looks at all of the cases and really goes deep into the data, the demographic data, the verbal autopsy, clinical abstraction, maternal abstraction, then all of the postmortem diagnostics that occur, with the ultimate goal of assigning a cause of death using standardized processes outlined by the WHO International Classification of Disease 10 guidelines, as well as ICD-PM, which is the ICD-10 applied to perinatal deaths. And basically what the goal of this is to fill out a death certificate, which is shown here. And for the remainder of this talk, when we talk about the causes of death, I just want to introduce some terms. So when the panel discusses these deaths, they want to list all of the conditions that they felt led to the death and record them as such, with the underlying condition being that disease or process that initiated the whole train of events leading directly to death, where morbid causes and immediate causes are diseases or complications that directly preceded or directly led to death. Additionally, The panelists record significant contributes that didn't necessarily lead to death, but that did contribute to it. This is where we can find a lot of risk factors for certain conditions determined by the panel. And most importantly, in addition to doing these causes of determining the cause of death, the DeCoDe panel also discusses if that particular death was preventable and what the public health recommendations are to prevent a similar death in the future. This DeCoDe process is standardized across the sites because, as I said, there's at each of the sites, there are a local team, but we wanted to make sure that there are standardizations. The first one is that we're adhering to the WHO standardization for determining classifying deaths. There is standardized training provided at each of the sites. And additionally, we developed a diagnosis standards, a document created that helps interpret the complete CHAMPS data. These are basically case definitions, but with the adaptation of what the CHAMPS data brings in, especially the extensive postmortem diagnostics and how it can be interpreted with levels of confidence. And then finally, there's an external quality assurance process, both within the network and external to the network. So cases are periodically shared between panels and assessed for their concordance, which always maintains a high concordance between each of the panels, as well as
Could you try again?
As well as for certain conditions, there have been external experts brought in to review some of the cases, again, with high level of concordance after each of those activities. So after a cause of death is determined on these cases, the final step in the circle is giving the family follow-up. So the information back to the family as well as to the community. And this is where the first data to action steps occur, just with the family, but also at that local level and with the community. So to show an example of that and to bring the whole process circular, here is a stillbirth that was enrolled. It was 35-week estimated gestation by LMP. The weight at the time of delivery was 3.8 kilograms. The history obtained on the mother, the 20-year-old, HIV positive, was diagnosed prior to pregnancy and was on treatment. It was a twin pregnancy. She did have the recommended for that area 4 ANC visits. The postmortem diagnostics done on the stillbirth, HIV, malaria, and TB testing were negative. The other twin was born alive with the APGAR at 7 and 8, with slightly under low birth weight at 2,000 grams. At the time of delivery, the condition that was felt to result in the stillbirth was obstructed behavior, or it's obstructed labor, sorry. But the testing, especially the TAC testing, revealed that Treponema pallidum was seen in multiple specimens. And then looking at the tissues, first starting at the tissue on the left, the liver, for those not familiar with histopathology, I will tell you all of that red staining that you see is not normal. Those are the spirochetes, the syphilis bacterium that are detected by immunohistochemistry that are just taking up all of the space where normal liver tissue should be. Additionally, in the lung, if you look close enough, there's a lot of the red staining as well, again, representing the spirochetes or the pathogens, and also in the brain. And I know it probably doesn't come through that well, but this is an extensive amount of pathogens in these tissues, which shouldn't be there. Additionally, looking at the placenta, which was obtained in this case, there is disease processes occurring in the placenta that could be attributed to the spirochete as well. In the last image on the right, the arrow shows these bacteria showing up, the spirochetes in the placental tissue. So when these results were discovered, the teams went back to the family, and both the mother and the twin were tested and treated. So this shows how just one case can make a big difference, because now, you know, the mother and the twin were tested and treated.
Di?
Yes.
We have a question about DeCoDe. This is a good one. Is a cause of death always determined? In other words, are there cases where it is not possible to determine a cause of death?
I will answer that in about 3 slides, but short answer, yes.
Great,
But
thank
I'll
you.
expand on it. Great question. Okay, so now as promised, we're going to take a deeper look into the current data and highlight some of the key findings. First, I would like to reemphasize that CHAMPS is an ongoing surveillance committed to releasing data in real time. So these numbers are always changing on a daily and monthly basis. But for this talk and the purpose of this webinar, we're just going to focus on what the data looked like in the middle of this month. And at that time, there were over 8,000 deaths enrolled, with over half of those undergoing a MITS procedure, and almost 3,000 deaths were complete with cause of death determination. And in all of these categories, the stillbirths and the neonatal deaths make up almost 3/4 of all the deaths. And on this slide, I know it's very busy, but just showing it to point out that the cause of death data that we're going to discuss in the rest of the talk is influenced by the contribution of cases from across the 7 active CHAMPS sites. So for each of these sites, the first column for each site represents the number and proportion of deaths within each age group that are CHAMPS enrolled. And the second column shows the same for the MITS cases, and the third for the DeCoDed cases, or those that have the complete cause of death data. The differences in the overall height of the columns is dependent on when the site initiated mortality surveillance, because not every site started at the same time. It's also influenced by the consent rate and the under 5 mortality rate. So in this slide, in several of the sites, and especially in the younger age groups, the overwhelming majority of the deaths being enrolled with MITS are deaths that are occurring within the facility. But the number of community deaths are increasing, and especially in the non-neonatal age groups. And here, looking at a very high level and a broad view of the main underlying condition or causes of death across the 3 age groups, there are some significant differences I want to highlight. So not surprising, we see that in the stillbirths and the neonates, the majority are causes that fall under the larger group of maternal and neonatal grouping, although the infectious and the non-communicable causes do increase as age increases. And this is true especially in the neonatal group, although not shown on the slide. But the late neonatal deaths, so those that occur after day 6, compared to those deaths within the first 24 hours or the early neonatal deaths, do have an increased contribution from the communicable and non-communicable causes, as opposed to the maternal and neonatal conditions. And then in the non-neonatal deaths, so the infant child population, we see that almost half are due to infectious causes, with significant contribution from the non-communicable causes as well. Now, going back to that excellent question before, there is the proportion of all of the age groups where the death is determined, there was not a cause of death determined, or they remain undetermined, even after a full investigation. But in all of these groups, that remains below 5%, which is very acceptable. There are previous studies that look at other specific groups of deaths, and in some of those, even with a complete autopsy and a full death investigation, about 15 to 20% remain undetermined. So for CHAMPS to maintain this undetermined below 5% shows that the process is really working. Okay, so now we're going to take a little bit closer look at those 3 age groups with respect to the underlying cause. And so looking first at the stillbirths, this heat map, just want to direct your attention to the purple, which represents the larger group of maternal neonatal, pretty much makes up the predominance of the underlying cause. So 73% of stillbirths have as their main fetal condition the asphyxia hypoxia as the predominant fetal cause. And again, the undetermined is 4%. And as mentioned earlier, CHAMPS also tries to capture the main maternal factor involved in these perinatal deaths. So if we look here at using the ICD-PM groupings of the maternal factors in the column headings, we can look at, for those cases that have the fetal condition of the asphyxia or hypoxia, we see the majority of those are due to a maternal factor of complications of the placenta, cord and membranes, or medical or surgical conditions. Within this group, the 227, the predominance of those are due to hypertension or eclampsia. And now moving to the neonatal deaths, we see that many of the underlying causes are still in the purple, or the maternal and neonatal conditions, with the perinatal asphyxia and hypoxia still being high at 27%. Neonatal sepsis and infections are increasing, as we previously mentioned. But the number one cause in the neonates is the preterm birth complications. And one of these preterm birth complications is respiratory distress syndrome, or hyaline membrane disease. And of the neonatal deaths, again, 44% had preterm complications anywhere in the causal chain. And of those, a majority, 65%, had this respiratory distress syndrome indicated as well. Overall, respiratory distress was in the causal chain of 28% of all neonatal deaths. And then an additional 2% had it as a contributory system. So RDS is a significant contributor to under 5, especially neonatal deaths. The image on the right just shows histologically what this, what the hyaline membranes, where the arrows indicating, are filling up the space where air should be transferring. So hence the name, the respiratory distress syndrome. A key thing I want to point out is that respiratory distress syndrome is preventable and treatable if recognized. And preventing our respiratory distress syndrome requires early and consistent A&C visits so that it's established a routine care and give physicians the best chance of identifying possible preterm labor risk. And if caught early, physicians can prevent or reduce the severity of RDS by administering antenatal corticosteroids that promote healthy lung development. Additionally, treatment after birth can include administration of surfactant to further reduce the severity of respiratory distress. Again, so since RDS is a predominant contributor to death, this is an important thing that could be used to prevent these as well. Okay. So now moving to the non-neonatal deaths, we see on this slide that the purple seems to be reduced. So the maternal and neonatal conditions are not as predominant, but now the infectious and the non-infectious causes are increasing. The number one cause in this population is malnutrition, and then the top infectious cause is malaria. So looking a little bit deeper into malaria, we see, as expected, when we look across the current 7 sites, there is a difference with the contribution of malaria anywhere in the causal chain, with Kenya, Mali, and Sierra Leone contributing significantly to these numbers. In Sierra Leone, it's responsible for almost half of the deaths in children 28 days to less than 5 years old. And looking just a little bit deeper into these malaria deaths, we see that about a third of them have malaria as the only cause of death. And the other, and 68%, or the other 2/3, where there's other causes, the majority of those other causes are infectious diseases, including sepsis, lower respiratory infection, HIV, and diarrhea conditions. Okay. It mentioned before about the malaria deaths that had other causes. This also underscores the fact that CHAMPS looks for and appreciates all causes or conditions that lead to death. So when we look across the age groups, there are differences in the number of conditions that the DeCoDe panelists record as causing the death. For example, in the infant child deaths, we see that almost half, close to 44%, have 3 or more causes identified. While unsurprising, in the stillbirths, over 3/4 only have 1 fetal condition identified. To show the importance again of these determining all causes, if we just look at lower respiratory infection or pneumonia, if we're just looking at it as an underlying cause, it only accounts for 4% of the deaths in non-stillbirth deaths. But if we look for lower respiratory infections anywhere in the causal chain, now we see that it contributes to 27% or accounts for 27% of the death, with variations within the age group, with almost half of the infant deaths having pneumonia in the causal chain. Another important aspect of CHAMPS data is that it can provide even further granularity with respect to certain cause conditions. For example, the etiologies of those lower respiratory infections or pneumonia deaths. And shown here, we see that Klebsiella pneumoniae and Streptococcus pneumoniae are the top pathogens associated with the lower respiratory infection deaths. The image on the right just shows, again, Klebsiella within the lung. The red staining by immunohistochemistry represents the bacteria in areas of where the lung has pneumonia or is diseased. Klebsiella, in addition to being the top etiology associated with pneumonia, also is the top pathogen across all of the conditions and all of the age groups. In CHAMPS specimens so far, Klebsiella pneumoniae has been detected in blood, CSF, or lung tissue in 29% of all cases. And again, this does differ with the age groups ranging from 9% in stillbirths to 55% in infants. It's in the causal chain leading to death in 14% of all age groups. And 79% of the Klebsiella deaths had sepsis involved. Again, just showing here, as I just mentioned, that there is a difference in the percent of each age group that Klebsiella, with the highest in the late neonate and infant population. Klebsiella is recognized as an important hospital-acquired infection, but we also see it contributing to a similar proportion of community deaths, with it being listed as 14% in all facility deaths and 14% of all the deaths that are occurring in the community. Another important pathogen that CHAMPS is starting to shed some light on is CMV. Here, showing it is detected in 22% of all of the cases, regardless of age group, and being in the causal chain in 3%. The image on the right on the left shows a classic histological feature of CMV inclusion bodies in a lung with CMV pneumonitis. Another important respiratory virus that CHAMPS is shedding some light on is RSV, or respiratory syncytial virus. It's important in under 5 deaths. And again, CHAMPS is detecting it in about 3% of these deaths, with about 1% being in the causal chain. And the image on the right shows a classic histological feature of RSV, or syncytial cells, in the lung. So the focus so far has been on infectious causes of death, but now we want to switch over to non-infectious causes of death. As you recall from the earlier slide, undernutrition or malnutrition is the top underlying cause in infant and children deaths that we're seeing in CHAMPS. And so in this slide, we want to take a little bit deeper dive into this data by the age groups and the extent of contribution of malnutrition. If we look at malnutrition anywhere in the causal chain, we see even a higher percentage of death associated at 23%, with an additional 7% of the deaths that have malnutrition listed as contributory. In these cases of malnutrition, almost all of them have an infectious disease process also in the causal chain, including sepsis and pneumonia and diarrhea conditions. Another very important non-infectious cause that we're detecting in CHAMPS is birth defects. Again, there's some variability across the sites and age groups with respect to contribution of birth defects to the deaths, with the highest proportion seen in Mali and Ethiopia. And specifically in Ethiopia, the high proportion of deaths due to birth defects is due to neural tube defects. And this slide shows the estimates of neural tube specific deaths in the 7 CHAMPS sites, again highlighting the high rate of these deaths in Ethiopia, where there is not a national folate fortification program known to be associated with neural tube. And so working with the Gates Foundation, Nutritional International, and the Ethiopia Public Health Institute plans to evaluate and initiate a fortification strategy to prevent these deaths in the future. And so lastly, keeping with this prevention and data, which is the ultimate goal of CHAMPS, we do see that the DeCoDe panels find almost 3/4 of all of these deaths could have been prevented, with the infant child deaths having the highest proportion, 78% of these deaths felt to be preventable. Specifically, one last note about the stillbirths is that additionally, we can look at the preventability of the stillbirths by what maternal factor, with the complications of labor delivery seem to be the most preventable at 89%, followed very closely by complications of pregnancy. So in this slide, I just want to quickly, again, put up the tease for a future webinar that will delve deeper into the data to action or prevention strategies. So as I just showed, the majority of the deaths that are enrolled to date of CHAMPS are found to be preventable with public health recommendations, depending on the age groups. And then within those broader buckets, we could then lead to more specific recommendations. For example, for the improved antenatal and obstetric care, fetal heart monitoring or oxygen therapy or cord cleansing. So many things that can be done with CHAMPS data currently, as well as when the CHAMPS data gets more widely distributed as well. And with that, I want to make another plug that CHAMPS data on an aggregate level is available in real time at champshealth.org. It's updated every night. There are monthly data sets that are released that can be just 2 clicks away, and to be downloaded. There are requests for additional data, custom data sets, or through different procedures to get some potentially identifiable data, as well as specimens. All of the specimens that are collected are part of a biorepository, which in the future will have more information on the website, as well as requesting of those. And so I'd just like to conclude that CHAMPS is extremely grateful and acknowledges the families and the communities that make our work possible, as well as, again, all of the partners that are part of the CHAMPS network. And soon we'll have 2 more countries on this slide. So I will stop there to make sure that we have enough time for other questions.
Thank you, Di. We do have a lot of questions, and they are good ones. I will direct them to you in the order in which they came in. So the first is, have you ever considered the role of mycotoxins, especially aflatoxins, in the role of infant and child mortality?
Yes, we did. So when CHAMPS, the lab and diagnostics plan, was being developed, we were very ambitious and wanted to be very inclusive and try to test for everything. Didn't take long to realize that it's not possible to be that. But we do, as we're collecting this data, we are refining some of the techniques in the diagnostics, and that has come up on the list a few times. So it's not completely off the books, but so stay tuned. We might be able to have some data on that in the future. Thank you.
Great, thank you. We have 2 questions now from the same participant. The first is, have you faced any challenges on religious bases for conducting MITs? I think the answer to that is yes, but would you like to give more detail there?
I will also refer you to the second webinar, which I think could probably address that more. Yes, there are, at many levels. I think the one that I probably would want to point out is we do have, when it comes to burial times in the past. So if you notice from some of the slides, we have many cases enrolled in CHAMPS in certain countries, but not a lot of MITs. And that is mostly due to the quick burial time that would, and these procedures are between 45 minutes and an hour, but still that does impact the cultural aspects.
Thank you. They also asked the question, why are radiological investigations not included for the determination of cause of death?
Another great question, and another thing that we thought hard about in the beginning. And it was trying to balance the resources needed for that, as well as the training with, and the fact that in most of these areas it's not available. So to bring it in for looking at these CHAMPS tests and not being used for inpatients weighed a lot into that decision to try to go with other resources.
Great. The next question is a big one. What strategies could be implemented to improve screening and enrollment of community deaths in the CHAMPS network?
Yes, that is a good question. So one of the, as I mentioned before, there's other surveillance taking place, so the demographic surveillance and the pregnancy surveillance, and that should help. So having community reporters in the community, having that strong community engagement and trust so that the deaths are notified in a more timely fashion, that could then, the family could be approached for MITs when it's still feasible. But I can't stress enough the teams that do the community engagement and assessment, that really is the building block of any success CHAMPS can have. And ultimately that is the goal, to do the best for the community. And so to have that two-way relationship is probably the key.
Thank you. Next, we have what has been put in place in order to reduce the undetermined causes of death. If I am right, they account for 4%.
Another good question, but I will start off with, as I mentioned, keeping it under 5%. I personally am pleased with those numbers, because if we had a really low percent of undetermined, that would make it seem like some of these deaths are being put into buckets by making a couple assumptions. And what we want is a standardized process across. And so many of those cases where it's undetermined are due to many reasons. One, maybe there's not, and we do collect this data, is the data not enough data? Is the data incomplete, or is it inconclusive? And if you notice the neonate, if you remember, the neonates had the smallest percentage. The neonates also have the highest percentage of facility deaths. So there's a lot of information collected on those neonates. And the more information, the easier it is to give an accurate cause of death. Where the infant and child and the stillbirths had the higher. And the stillbirths, many of those deaths that were undetermined are due because there was not good maternal history available. And in the infant child, there is a strong correlation with those that are undetermined and being community deaths. Again, with the community deaths, most of those cases, the only information that's available on symptoms or signs or events preceding the death are from the verbal autopsy, which, depending on the responses to the questions, may or may not provide that much information. So that's why, you know, it's not unreasonable to have 4% of these deaths being undetermined, even after the MITS procedure and all of the other investigations.
Thank you. Scott asks, why is CMV so rarely in the causal chain despite frequent detection?
That is a great question. And so similar questions were brought with other pathogens. And so just detecting a pathogen, again, we have that the TAC-MIN array cards, which detects over 130 pathogens. And so just detecting a pathogen does not necessarily mean it's causing a disease. There are certain pathogens that we know are commensals, or that we have in our body all the time. And one little fun fact, you have more bacterial cells in your body than you have own cells. So keep that in mind. But with respect to CMV, just detecting it again, and in those cases where it's detected and the disease, the clinical signs do not match or are compatible with a CMV infection, or the tissues do not show any evidence of disease processed by CMV, the panels do not feel that, in some cases, it's quite clear, it might not even be an infectious death. So again, just detecting the pathogen does not necessarily equate with disease, and especially does not equate with cause of death.
Thank you. There are more questions, Di. We have excellent questions today. Next is approximately what proportion of infectious causes of death by age group would meet a definition of healthcare associated and or hospital acquired infections?
Oh, that's a great question. And I'm going to give an estimate. So of total, about a little over 50% of the deaths are in infectious causes. And so of those, the ones that were hospitalized long enough to be hospital associated do vary with the age groups, with the neonates having the highest proportion. I'd have to go, and this is, I should have this number off the top of my head, but I don't, of how many of those would fall under the hospital acquired. In some sites, it is quite high because of known nosocomial outbreaks. But that is a great question, but we'll have to get back to you on the exact numbers. But again, the neonates have the highest, and the infant children, the children are the lowest, and the infant is somewhere in the middle. But again, and then if you look closer at the infants, it's those 1 to 3 months that would be higher than the 4 to 12 months. Great question. Oh, and one other answer to that is that, and a plug for downloading the data. If we're not quick enough to get that response back, you can download the data and look for yourself. Excellent
point. The next question is sort of a compound question with a few queries in it. So this person asks if malaria cases were diagnosed in neonates or in infants. They also say, it seems like it is associated with malnutrition or the contrary. Overall, looking at all sites, what is the most common cause of death in neonates? Asphyxia? So a couple different questions in there.
Okay, the first one, the malaria, can you remind me what?
She writes, my question is if the malaria cases were diagnosed in neonates or in infants.
Yeah, so there's been, I think, one late neonate, but the majority are in the infant and children. So yes, it's been diagnosed. And probably there's an equal distribution, or actually the majority of them were diagnosed post-mortem. Some of them did have tests done right before death and started on treatment, but not soon enough to prevent the deaths. And there is an association with malnutrition, but because malnutrition is predominant in the same population where malaria is, it's not a significant correlation or association.
And then the final part was looking at all sites, what's the most common cause of death in neonates with a guess at asphyxia?
So it's actually preterm birth complications with the low birth weight and the RDS that I showed an example. But across all of it, of the neonates, it's preterm birth complications and then all the sequelae that come from that.
Thank you.
Great questions.
Next question is, were many of the deaths considered to be vaccine preventable?
That is an excellent question. So, and I did not include from there, Streptococcus pneumoniae is a good example of that. We do, if you remember from the lower respiratory infections, it was the #2 cause. It does contribute significantly across all the age groups, even without pneumonia, within sepsis or meningitis. It is a vaccine preventable. We are in the process right now of delving deeper into those cases to get the serotypes to see if it's being caused by the same serotypes that are in the vaccine, and then go back to the sites, to the countries where this vaccine is in use, and also to look at the history of those children to see if they were properly vaccinated against that. So stay tuned on that as well.
Next question asks, are CHAMPS sites surveying antibiotic resistant bacterias, and what are the roles of these pathogens in mortality?
Another excellent question. Yes, we are. So all of to remind that the culture is done on the blood and CSF. And if there are isolates recovered from the blood and CSF, they are tested for antimicrobial resistance. And so unfortunately, we are seeing resistance in many of the certain pathogens, for example, Klebsiella, that is being isolated. The overall contribution of those to the under 5 mortality, we don't have that number right now because right now, as I said, we're getting it from the isolates, and we have many cases where that bacteria or certain bacteria are in the causal chain, but the isolates, we don't have isolates. It's based on other data, the TAC results, and also looking in the tissue. We are looking into doing molecular typing for resistance so that we can get a better estimate of the role overall of antimicrobial resistance in under 5 mortality.
Thank you. Next question is there a plan for transitioning to ICD-11?
Yes, there is. And I know that it's being brought out this month or in April. It will. We would want to make sure that we have everything in place for the standardization of this because it is such a big jump from ICD-10 as opposed to an ICD-9, ICD-10. But yes, there is a plan. But yes, we'll just leave it at that. Don't tell our informatics team that yet because it's going to be a hard data management issue, but we can do it.
If anyone can, they can. We have a couple more questions here from one person. The first is, can you elaborate more on data to action? And then the second is, I was wondering what is the distribution of stillbirth according to site? So one of those might be a more simple answer than the other.
To elaborate on data to action, I kind of want to wait till the next webinar because I don't want to steal that too much of a thunder. But I will tell you the instantaneous data to action that happens when each of these sites start bringing together the DeCoDe panel is that from each of the first DeCoDe panels of all of the sites, there was one major takeaway from all of those, which was the data to action part, is that going through these histories, they saw that the medical record keeping at their main facility was not, could be improved. And so instantaneously, they went back, they did retraining and worked with the hospital to get better records. And again, other examples come up when they see that there is a predominance of malnutrition in the area. They bring together panels and do community education and try to look for ways to improve the nutrition in the community. But many examples. Again, I don't want to take too much away from the next webinar. And also to point out on the website, there are case examples that highlight some of the data to action activities that have already taken place within the network as well.
And did you want to give an estimate of the distribution of stillbirth according to site?
So, it is for the site, the ranges are about 23. Let me see if I can get back to that slide. No, my computer's not cooperating. But it is about 2/3 or 1/3 in each of the sites. There are some sites that, because of the facility is the major labor and delivery, a little bit higher, but across all of them, it's about 1/3 of the deaths enrolled.
Another data to action question we have. In terms of data to action activities and looking at the current data, what would be your suggestion on priority actions?
So the prime example of Ethiopia with the folate fortification, for a common across all of these sites which have been implemented is the infection control and prevention in their main facility, where they are seeing an increase of, for example, the Klebsiella death. So just going in and reevaluating the infection control practices in the hospital is a key one, as well as retraining for management of ICMI signs or proper antibiotic use. So which one is the priority? I would say all of them.
Good answer. We have a question here that says, for the early neonatal deaths, what was the contribution of birth asphyxia?
So outside of the preterm birth complications, the birth asphyxia is the second leading cause. Anywhere in the causal chain, I think it probably falls, if I remember the numbers correctly, around 30 to 35%.
Thank you. Next, I'd like to ask about findings regarding congenital heart defects. The GBD shows an increased contribution. What does our data show?
So, and I did not, as much of great data that CHAMPS have, there are some limitations. And so when it comes to some congenital defects that do not have gross manifestations, such as neural tube defects or other birth defects that have, obvious abnormality seen, with congenital heart defects being one of those that does not have an outward detection. We don't, in even the heart biopsies that are taken, cannot diagnose congenital heart defects. So we do have some cases where the DeCoDe panels have put congenital heart defects as the causal, just based solely on clinical findings, as well as ruling out some other known causes that could be compatible with those clinical findings. So for that, the estimates we know that we're missing some congenital heart defects.
Let's see. I'm going to skip around a little bit here. I know we have just a few moments left. If there are questions that are in the chat or in the Q&A that we don't get to within the hour, we'll make sure we post answers to those questions on our website when we post this recording and the slide deck as well. But we're going to do our best to get through the remaining questions. Let's see. Being futuristic, where do you see this project when it comes to government engagement, taking into consideration that the laboratory component is one of the main bottlenecks in LMIC?
That is a great question too. And so one of the key partners in the CHAMPS is the International Association of National Public Health Institutes. That hopefully will be that bridge to the government. When it comes to respect to the lab, we do have some of the sites, strong collaboration between the CHAMPS lab and some of them, they actually sit in a district, the Ministry of Health district lab, as well as having strong partnership with it. Idealistically, in the future, we would want CHAMPS to be implemented by the local or national government to be sustainable, not necessarily in the full capacity it is now, but to keep up the mortality surveillance, the recognizing the under 5 mortality, and most importantly, to make sure the accurate causes are known so that it informs the strategy of prevention and treatment.
Thank you. Next, we have our investigations carried out on women who experience stillbirth as well. For example, testing for group B strep infection, which is known to cause stillbirth.
At this time, standardized across the sites, no. In the pregnancy surveillance, which is starting, that is something that can be added on to do maternal testing, but as a whole right now, no.
Okay.
Good question. But then, one last thing on that. So going back to the third objective of CHAMPS, to have that platform to build on, that, if other groups come in or other associations, it provides that platform, especially with the pregnancy surveillance, to undertake that.
Thank you. And now we have recent studies showed soot or black carbon is visible in placenta, and indoor air pollution is the most common one in these areas. Is it possible for CHAMPS to detect that soot?
It is, and I almost put a slide in. So we have, and that's the power of the pathology. So there are many cases, unfortunately, where in the lungs we see that black in the disease caused by it. So yes, it can detect it by the tissue specimens.
Thank you. There's one more question that went back to CHD. They say often pneumonia is the cause of death, but the underlying cause is heart defects. So they're often conflated. Do you want to add anything to that?
Yeah, just to repeat that it is a known limitation that we can't detect that. And again, to stress, especially in those cases where it's not a lot of clinical history, we are limited to what we can tell at the time of death. And so in an ideal world, we would have the complete history that we could look back. So in some of these, it may not be the big story, but it is what was the situation at the time of death.
Thank you. I think I have time for maybe one more. In our DeCoDe process, do we give strength or level of evidence for those results?
Great question, and I left that out. Yeah, so part of that diagnosis standard, that document that we created to help standardization, has the case definition or the disease process, as well as 3 levels. So level 1, level 2, and level 3, with level 1 being the highest level of confidence. And so, for example, in a case of pneumonia, where there is histological evidence, so definitely a disease process seen in the lung that can be attributed to bacteria. There's bacteria seen within the lung, immunohistochemistry specific for that bacteria, and molecular results specific for that bacteria. That case fits the definition of a bacterial pneumonia with a level 1, where level 3 would be there's still strong evidence of that process, but maybe not as strong as seeing the bacteria within the lesions or seeing the TAC. So yes, there are levels of confidence for each of those diagnoses.
Thank you.
And again, plug for the website. Those diagnosis standards are available on the website as well.
Yes, yes, they are. Thank you, Di, so much. And thank you to all of our participants. It's wonderful to have so many smart, discerning questions coming in and such active participation from everyone. Several people asked about slides and recording. The presentation slides will be made available to you, and the recording of this session will be available as well. Everyone who registered for this webinar will get an email with that information, but we'll also post it on our website and our social media, so it should be accessible for everyone. Previous webinars are also available on our website for you to go back and look at, since we talked a lot about the SBS webinar from November. We didn't get to answer every question. We got close today. I have made notes of all the questions we weren't able to answer, including some of the ones that were in the chat. We'll get answers to those posted as well. And if you have questions that you didn't ask in this session but would like to follow up, please do reach out to us at info@champshealth.org, and someone will get back to you shortly, and we can post responses to your questions on our website as well. I would like to remind everyone to follow us on our social media and also to subscribe to our email list. It's the best way to get updates about what's happening at CHAMPS, including more webinars like this one. Also, as Di pointed out, please go explore the website and look at our data. It is available for you to download for free. So thank you again for joining us all today. We're glad you could make it, and we hope to see you soon online or in person.
Thanks, everyone.
Take care. Thank you.